screen.
Yeah, I'm just. Are you seeing the presenter mode or the?
Yeah, just switch the mode.
All right. Okay. Sorry about that, about the delay, but thanks for the intro, Umesh. I just want to present a couple of the many updates from the American Thoracic Society. Obviously, we hadn't met in almost 2 years in person, 3 years really. So there was a lot of fun times to be had. And this is just like a brief overview, and please feel free to interrupt me, add whatever additional things you might have seen when you were at ATS, and I want it to be as interactive as possible. I have no disclosures, and I want to briefly start by saying this is like a very small part of a lot of the ARDS and critical care work that was done. I'm actually going to limit it not to COVID because I feel like we've been overloaded with COVID, but some of the other stuff that I saw at ATS. So with a lot of research that's being done in specifically ARDS related, kind of triggered by the pandemic that we just had, I just wanted to focus on these 4 topics. And I want to give a shout out to Kusum, who actually shared her slides. These are a lot of the slides that she used to present her clinical year in review for ARDS at the ATS. So I'm going to start by first actually just briefly going over like our definition of, or the accepted definition of ARDS. As most of us know, it has to be acute onset, it has to have bilateral airspace opacities, and it has to be respiratory failure that's not completely explained by cardiac failure or fluid overload. But there's no need for like objective assessment of like hydrostatic pressures. It's just like it cannot all be explained by cardiac failure. But the key part that I want to highlight is that the oxygenation is what determines ARDS severity and also whether they have ARDS or not. And these targets have been set primarily using also requiring that the patient be on a certain amount of PEEP or CPAP. That requires that they have to be on either invasive ventilation or they have to be on a CPAP or a BiPAP mode. But as we've all experienced during the pandemic, we have used high flow significantly in a lot of our patients who clearly have all of the signs of ARDS, but they technically don't qualify for ARDS because they are on not a PEEP mode or a CPAP mode. So there's been a lot of discussion and a recent article by Mathe and colleagues that kind of calls into question our current definition of ARDS and proposes that we expand the Berlin definition to include patients who are at least on 30 liters per minute of high flow, because high flow has been shown to give flow dependent and expiratory airway pressure of at least 2 to 5 centimeters of water. And most studies have shown that the degree of hypoxemia is more reflective of outcomes. And since we're now able to support patients with severe hypoxemia with just high flow, that including these patients will actually help us improve our care for our ARDS patients, but also help it be more reflective of the outcomes that we see in these patients. So a lot of the studies now that when I think of ARDS, I think of people who are having acute hypoxemic respiratory failure. And to that end, I want to talk about subphenotypes. And I was actually on my way to the JAMA New England Journal update on pulmonary medicine when I kind of got sidetracked by a pro-con debate on whether or not subphenotypes are helpful. So I want to highlight one article that, another article that came up recently about using subphenotypes and latent class analyses to help categorize them. So latent class analysis is basically it's a modeling approach that helps us better understand the heterogeneity of ARDS and to try to help group this heterogeneous group of patients into a more homogeneous subgroups or based on like either their clinical or biological variables. As I think I did this a couple of years ago, and I presented 2 RCTs at the time, which actually did latent class analyses on the ARDSnet studies to show that there's the two most common subphenotypes were a hyperinflammatory and a hypoinflammatory phenotype. But as we all know, RCTs are usually involve very specific types of people with a very protocolized intervention. So we weren't really sure if these latent class analyses that were done on this very select group of ARDS patients actually are generalizable to the real world setting. So this article, or this study by Sinha and colleagues, actually did a latent class analysis on subphenotypes of ARDS that are in prospective observational cohorts. So the data sets they used essentially included two large observational cohorts. One was the VALID, or the Validating Acute Lung Injury for Markers for Diagnosis cohort, and the earliest assessment of renal and lung injury cohort, which is the early cohort. They actually used the American European Consensus Conference endorsed definition of ARDS, which actually does not include PEEP or CPAP setting as one of the categories for defining ARDS. They also did an analysis of the Berlin definition of ARDS. These data sets included very detailed clinical, lab, and biomarker data, which allowed for latent class analysis at the same level compared to the previous RCT trials. Just a quick note, the VALID cohort actually had about a third of patients who had trauma, so they did both an analysis with and without trauma patients. So what did the actual analysis show? Both the VALID and the early cohorts using the new definition, which did not include PEEP as a requirement, revealed that there are two subphenotypes as consistent with the previous studies, which is the hypoinflammatory or the hyperinflammatory phenotype. So to understand this graph, the x-axis reflects all the different variables that were looked at, and the y-axis are the standardized values on the mean standardized values. So the red line is the hyperinflammatory, and the blue line is the hypoinflammatory phenotype. And you see at the edges is where they separate out and are different. The authors tried to use a parsimonious classifier model. So they used both a 3 and a 4 variable model, and they both had very good AUCs. They found that IL-8 bicarbon protein C are very helpful in differentiating the two types of phenotypes, and with or without vasopressor use. That's the 4 model. And why do we care? So we've differentiated the two types of phenotypes. Why is that important? It's important because the different types of phenotypes have very different outcomes. The two-class model, these two different phenotypes, the hyperinflammatory subphenotype had fewer vent-free days and a higher in-hospital mortality in both cohorts, both the VALID and the early cohorts. And this was consistent with what they actually saw in when they did this type of analysis in the ARDSnet RCT. Right. So to quickly summarize, our take-home points are that the hyper and hypoinflammatory subphenotypes grouping holds true for both real-world data and is consistent with what we saw in our RCT data. The 3 and 4 variable classifier models are also very discriminatory for these groups. You don't have to put 5 or 6 or multiple variables to help differentiate them, and these actually reflect outcomes. So the latent class analysis informed subphenotypes are associated with ventilator-free days and mortality. And in the future, we can actually potentially use point-of-care assays like we've done in the past with IL-6, for example, and tocilizumab, and use the available clinical data to help subphenotype our patients and potentially have an actionable plan that is tailored to the patient and their particular phenoendotype. The next big area of management that I found interesting, this is a topic that's near and dear to my own research, is how do we select a mode of ventilation for patients that we see who are presenting with acute respiratory failure? Is it invasive ventilation, high flow, non-invasive, CPAP, bilevel? There's so many options available to us now. So how do we select, and really what are the outcomes associated with these different types of modalities? So the first study I'll talk about is the Recovery RS trial that was just published in the JAMA. I'll preface this by saying previous studies in non-COVID patients, like the Florali's trial, actually showed a benefit for using high-flow oxygen versus using NIV versus standard oxygen therapy to improve outcomes in very severe acute hypoxemic respiratory failure. So this study it has very different results, and we'll kind of go, well, not very different, they're different results, and we'll go through them. So the cohort itself was all adult patients with COVID-19 who had acute hypoxemic respiratory, hospitalized with acute hypoxemic respiratory failure, and they had about 1,278 patients. This is an interesting parallel group, open label, adaptive, randomized controlled trial across 48 acute care hospitals in UK and Jersey. So with the parallel group, they basically share a control arm, which is the conventional oxygen therapy. So they compared, for all essential purposes, they compared CPAP versus conventional oxygen therapy or high flow versus a conventional oxygen therapy. It's important to note that there's a lot of high crossover between the arms. They did do some statistical inverse probability weighting to account for this bias, but of course, the trial itself was actually halted early due to waning COVID numbers. So that actually influences some of the outcomes we'll see. And it's also important to note that there was no BiPAP, but this is just CPAP that's used, which is very different than our own practice. I feel like we rarely use CPAP. We mostly use BiPAP in our own hospital. So the primary composite outcome, which is intubation or mortality within 30 days, showed that the odds ratio for CPAP was actually statistically lower than conventional oxygen therapy. So the study essentially found that fewer patients treated with CPAP met the primary composite outcome of intubation or mortality within 30 days as compared to those treated with conventional oxygen. This is an absolute difference of 8% in the adjusted analysis. And in the adjusted analysis, 32% lower odds of the outcome if treated with CPAP. But if you actually look closer at the breakdown of the composite outcome, you see that it's primarily actually driven by intubation and not mortality. It's an intubation benefit to prevent intubation, but not a mortality benefit. Some key aspects to note is that the timing of intubation itself was not standardized. This is a pragmatic trial, and the patients who were actually on CPAP were less likely to be admitted to an ICU, and the monitoring on the floor is very different than step down or the ICU, and might be also affecting the decisions to intubate. The other thing to note is that there was no significant difference between high flow and conventional oxygen, but the study, because it was halted early, wasn't necessarily powered adequately to actually see a difference with high flow versus conventional oxygen. In terms of adverse events, the CPAP group had 34% adverse events with emphysema, pneumothorax, and aspiration. High flow had 20%, and conventional oxygen had 13%. Some other studies that that it would be interesting to look at, but I won't go into, are the HOT study, which actually looked at helmet non-invasive ventilation versus high flow in COVID in severe hypoxemic respiratory failure, and another study that was looking at that had similar results for high flow versus conventional oxygen therapy on changing invasive mechanical ventilation days in severe COVID. The high flow COVID trial did not find a benefit with high flow in reducing the risk for needing intubation and clinical recovery. These are studies that kind of are in keeping with the Recovery RS trial. So in summary of this particular group, the early use of CPAP in COVID-19 respiratory failure might help stave off intubation. High flow may help, although, like I said, it was underpowered to see this effect. And intubation timing is subject to bias from physician to physician, and actually even the patient location, and might have actually affected the outcomes that we saw in Recovery RS. And again, we've seen this in practice bear out that the vent modality choice was significantly affected by changes in practice, resource availability as the pandemic progressed. The next big update that I thought was interesting was PEEP targets and how we're selecting our titration. So this is actually a reanalysis of the EPVent-2 trial that was done earlier last year, a few years ago. Similar to the Subphenotypes paper, this study looks to explore essentially the heterogeneity of the ARDS population and who benefits from the different PEEP strategies. So I just want to recap quickly what the EPVent-2 study was about. So this was a cohort of moderate to severe ARDS by the Berlin definition. It was a multi-center randomized controlled trial enrolling patients with moderate to severe ARDS, and it compared essentially the esophageal pressure manometry guided PEEP titration against an empirically high PEEP strategy. And it essentially found no difference in mortality. The reanalysis by Dr. Sarge and colleagues had two main aims. The first was to perform a risk-based analysis and to see if there was an outcomes difference based on the level of multi-organ failure or severity of illness using both the Apache and the SOFA scores. The second was to perform a more mechanistic exploratory analysis where instead of comparing groups, they looked at how close the patients were to the target transpulmonary pressure of 0 and whether that made a difference in outcomes. Both analyses focus on the heterogeneity of treatment effect, where non-random explainable variation in outcomes in the direction or the magnitude can be attributable to the individual subgroup characteristics. So you want to so for the risk-based arm, the authors essentially found that titrating PEEP guided by esophageal manometry did make a difference, but depended on the Apache score. There was a significant interaction. As seen in this forest plot, those with the lower Apache 2 score had lower mortality when using esophageal manometry guided PEEP, but the opposite was true for those who had a high severity of illness, which is actually counterintuitive to what you would think. The mechanistic findings were also quite striking. If you look at, we remember that overly negative, like when we have a very large transpulmonary pressure, you can have atelectatic trauma, and an overly positive pulmonary pressure, you have overdistension. So the goal was to target the transpulmonary pressure of 0. The authors found that the further away from the target of 0 you are in either direction, the worse off you are, which you can see with the Kaplan-Meier curve. So the closer you are to 0, the better your survival, and the further you are, the worse you did. So this effect was independent of treatment group and the severity of illness. So the higher end expiratory transpulmonary pressures were also associated with a higher risk of shock. So what did our takeaways from this study essentially are that patients with low severity of illness appear to benefit from esophageal manometry guided PEEP titration. And then that as a mechanistic target, targeting a transpulmonary pressure of 0 is associated with better outcomes. And the higher end expiratory transpulmonary pressures may harm patients with shock. And patient subgroups can have a differential response to ICU treatments, which kind of is in keeping with what we saw in our first study, where we know that all patients are not equal, so all therapies should not be delivered equally to them, as in like everyone does not benefit from this the same strategy of treatment. And finally, in terms of ARDS, I want to talk about some oxygenation target trials. We've had several several studies come out recently about oxygenation targets, but the one that I'm going to focus on is on the HOT-ICU trial. This trial is a multi-centered stratified parallel group clinical trial in 35 European ICUs. They were primarily adult medical ICUs and patients with acute hypoxemic respiratory failure requiring at least 10 liters per minute of supplemental oxygen or greater than 50% FiO2, either by invasive or a non-invasive modality. They targeted a low PaO2 of 60 versus the high group of 90, and they were titrating to ABGs. As the ABGs were not mandated, the units titrated the oxygen to maintain peripheral oxygen saturation readings corresponding to the arterial oxygenation saturation associated with the targeted PaO2. So the ranges of the SaO2 readings, the median were 93% in the low target group versus 96% in the high target group. As you can see in the figure 2, there was nice separation between the two arms of the high versus the low the oxygenation target strategy. So the primary outcome was all-cause mortality by 90 days, and they found no difference in mortality after adjusting for trial site and baseline variables of COPD or cancer. In contrast to the previous studies examining low oxygen targets, the HOT-ICU trial actually found that adverse events, namely shock, myocardial ischemia, ischemic stroke, or intestinal ischemia, were actually similar in the two groups. So having a more aggressive titration also did not help get patients off the vent sooner. So they found no difference in the number of vent-free days. But the other thing I want to kind of point out that was important, that we've actually heard a whole talk about this from Dr. Richardson earlier this year, is that the use of peripheral oxygen saturations to help guide protocol adherence. So they also did not. The study also did not look at race or ethnicity data in their patients and did not include that in their table 1. And in the last year we know that there have been many studies looking at the accuracy of peripheral oxygen saturation, specifically in patients with different or darker skin pigmentation. So this study by Wong and colleagues is actually a cross-sectional study of 5 databases that looked at the Electronic Intensive Care Unit Clinical Research Database and the Medical Information Mart for Intensive Care 3 and 4, as well as the Emory Healthcare and the Grady Memorial databases spanning 215 hospitals and 382 hospital ICUs. And they found, and they had readings for about 87,000 patients with peripheral saturations reading greater than 88% 5 minutes before an ABG. They defined hidden hypoxemia as arterial oxygen saturation of less than 88% when the peripheral sat actually was greater than 88%. And the authors found significant disparities in both pulse oximetry accuracy as well as across self-reported racial and ethnic subgroups, especially with Black patients at 6.9% and Hispanic patients at 6% disparity compared to Asian and white subgroups, which both had an incidence of 4.9%. So hidden hypoxemia was also associated with mortality, future organ dysfunction, and abnormal laboratory test results. So just wanted to specifically call out that there's a sizable percentage of patients within racial and ethnic subgroups that have hidden hypoxemia that are associated with worse mortality, SOFA, and lactate. And these patients, and this is kind of the target they used in the HOT-ICU trial without taking into consideration that there might have been some data acquisition error. So just to summarize our oxygenation takeaways, the HOT-ICU trial, the lower PaO targets do not seem to negatively impact mortality outcomes, but having these targets don't necessarily seem to improve or reduce the time the patient spends on a ventilatory target on the ventilator. And certain subgroups may actually benefit from a low target, but the trial does not. The trial does not really talk about which subgroups they are, and it does not support. But it does support the safety of future studies as it showed that there wasn't a significantly worse outcomes associated with targeting a lower, or adverse outcomes associated with targeting a lower PaO2. And it's very important for us to also consider hidden hypoxemia, especially when we're using a peripheral oxygen saturations to guide our ventilatory titration. In our final section, moving a little bit away from ARDS, I'm going to talk about some updates and I got some fun articles that have to do with resuscitation. So the surviving sepsis guidelines were updated recently and published. So I just wanted to go over in 2001 some of the changes that were made to the previous surviving sepsis guidelines. This is the 5th version of these guidelines. They essentially used the systematic review and grade methodology to help put out statements about what is recommended or what are best practices. And they have 5 different domains. They had screening versus and initial resuscitation, infection management, hemodynamic management, ventilation strategies, additional therapy section. And they added actually a new section that focused on goals of care and long-term outcomes in patients and survivors of sepsis. Interestingly, the first thing they did was they actually changed the recommendation grade on the recommendation to at least use 30 ml per kg of initial fluid resuscitation in patients with signs of hypoperfusion. What they did was they changed the recommendation and it was downgraded to weak due to low quality of evidence. Why this is important is that that weak recommendation actually allows for some variation in practice to say that if it's not appropriate for a patient, that you don't necessarily have to use the resuscitative initial fluid strategy. They also recommended against using Q-SOFA as the only screening tool for identifying sepsis, and this was a strong recommendation with moderate quality evidence. And they had recommended against using vitamin C, which is actually supported by the latest trial that just came out showing a worsening mortality in sepsis patients who got vitamin C. So that was but this was based on previous data. The interesting thing they did recommend for was that they actually said using capillary refill time would be a great alternative target to guide, resuscitation. I have to say that this time they actually included representatives from areas of like low resources. So they also included other ways to help identify and treat patients with sepsis that in resource poor areas as well. They also provided a weak recommendation for the initiation of vasopressors peripherally if needed. This is based on data that show that time spent in a hypoperfused state matters and can impact outcomes in patients. So if it means that using a peripheral vasopressor means that the patient is perfused quicker and in a more timely fashion, that they should be initiated peripherally. And it's also beneficial in areas where central lines might not be as easily available. They provided a weak recommendation of balanced solutions over normal saline. They also recommended high flow nasal oxygen over non-invasive ventilation for patients with sepsis. This was a weak recommendation. And then they issued 2 best practice statements, and that was that essentially for all adults with septic shock or sepsis, they want med reconciliation both at hospital and ICU discharge, and that was a best practice statement. And for adult survivors of sepsis and septic shock and their families, they recommended including information about the ICU stay, sepsis and related diagnoses, as well as like what needs to be done and followed up as an outpatient, including both follow-up for assessing new and worsening physical, emotional, and cognitive decline in the post-ICU setting. Oh, I'm sorry, this is... So what can we take away from the surviving sepsis guidelines? One is that we don't necessarily always have to give 30 cc's per kg for initial fluid resuscitation if it's not appropriate in the patient. Physical exam findings can help guide resuscitation and not just laboratory values. And time of hypoperfusion matters. Therefore, peripheral vasopressors can be administered if needed acutely. And pre-ICU discharge planning and post-ICU care is important for functional and cognitive recovery of patients, of survivors of sepsis. The next study I want to highlight is actually for our nursing colleagues as well as us, and it's a study that was done for the prevention of catheter-related bloodstream infections. This is an interesting study. We know that guidelines, I didn't actually know this because I didn't know infusion sets were replaced every 4 days, but guidelines suggest the replacement of infusion sets every 4 days to prevent catheter-related bloodstream infections. But the evidence to support this practice is pretty weak. So in this study that was actually conducted in 10 Australian hospitals. It was a randomized controlled trial. It was assessor mass trial. They had adults and children who basically had a catheter that was expected to stay in for more than 24 hours. And they used both central and arterial lines. And the intervention was to change the infusion set every 7 days versus 4 days. And the incidence of CLABSI was adjudicated by a mask physician. This is a parallel group, open label, adaptive, randomized control trial. And what they found was that for the central venous access group of almost 2,000 patients, the incidence of CLABSI was 1.8% in the 7-day group and 1.46% in the 4-day group, and there was no absolute risk difference between the two groups. For the 7-day infusion set use. Some of the critiques of the study was that it was not matched to the participant and there was no protocolized testing of blood cultures. So this is, again, a pragmatic trial, but it did find no difference in the reported number of CLABSIs between the 7 versus the 4-day group. They also had very heterogeneous group of catheters, location, and the types of infusions that went through the catheters. So it's just, this might not be you can probably not extrapolate this to all types of infusions and catheters, but it's just I thought it was an interesting study that was done to look at the safety of from a different perspective. I've not read a trial like this before. And finally, I know we've had a lot of studies recently on like the basics and the ANZIX trials, all of them reporting results, but I just wanted to focus on a particular type of resuscitation, which was in the pre-hospital setting. This study was actually, the refill trial was conducted to look at in adult patients with trauma related to hemorrhagic shock and hypotension that was defined as FBP less than 90 millimeters of mercury or an absent radial pulse. And it was done in an allocation concealed open label parallel group randomized controlled, phase 3 randomized controlled trial in 4 civilian pre-hospital critical care services in the UK. So this was all done in the pre-hospital setting, and the intervention was either giving packed red cells and Lyoplast versus normal saline. The primary outcome was a composite of was either mortality while they were during this particular admission or impaired lactate clearance, which is defined as not a reduction of lactate of less than 20% than the baseline every hour, or both. So the composite outcome actually occurred in 128 or 64% of the participants receiving PRBCs compared to 65% in the saline group, and there was no significant difference in the adjusted risk difference. The serious adverse events that were included were respiratory distress in 6% of the PRBC group and 2% in the patients receiving saline. What I thought was cool about this study is that it demonstrates that you can actually do large randomized controlled trials in the pre-hospital critical care setting, but also there is safety in that it's actually safe to give RBCs if you need to outside the ICU. And with that, I'm going to stop and ask for any comments or questions or anything.
Thank you so much, Dr. Goel. A quick overview of the relevant evidence that's important for us. Very interesting, large study about the discrepancies between pulse oximetry and ABG in minority communities. Can you explain the physiology behind that, please?
So that's actually interesting because it has to, I personally don't understand the details of the technology that's actually used, but it's supposed to do with the light sensor that's actually used to determine the peripheral oxygen saturation, and how it's actually theoretically was calibrated, perhaps using more patients with lighter skin tones than darker skin tones. I know there's been several articles that have come out, and the pulse oximetry, some of the companies have put out a statement saying that they don't have this problem, but there's actually not been prospective studies studying this to either prove it or to debunk or to validate it, and that's something that that needs to be done going forward.
Perfect. There's a question from David Butler on the chat that says, did you say it was 4.9% versus 6%?
So it was 4.9% in, so I just want to double check, but it was 6.9% versus 4%.
Got it.
The hidden hypoxemia, is that what you're talking about?
Yeah.
Yeah. Sorry, I'm just gonna, yeah.
Jean-Pierre, did you have a question? You're on mute.
So greeting to everyone. Sorry, I came a little bit late. I was driving back home. So I don't think I have a question at the moment.
Okay, thank you.
Otherwise, it was a great presentation.
Thank you. Where are you?
In Rwanda.
Understood. Got it. Thank you so much.
Yes, welcome.
Dr. Dua.
No, that's just me. It's my fellows that my Ethiopia program that I go to volunteer every year. So some of the attendees on this are going to be the ones attending from East Africa.
Excellent.
Yes.
Excellent.
Neha, you are famous now.
Global Critical Care Medicine in Action.
That is right.
Led by Dr. Dua and Goel. Cannot forget Dr. Lay. Where's Dr. Lay? Okay, listen, if anyone has any other questions, please speak up or forever hold your peace, because Neha is super busy and she has to go back to her ICU. Thank you, everyone.
Thank you.